I'd like to begin today by giving you an overview of the agenda. We'll be looking at Latinos in the U.S., first starting with a look at HIV epidemiology, looking at optimizing HIV care, the impact that the Ryan White program has on access to HIV care, the individual, clinical, and organizational barriers, a look at the Latino HIV workforce, and finally, community models for addressing HIV care. Our presenters today are a diverse group representing a variety of areas, as you can see from the slide here. And in addition to myself and Jesus Filizola from Health HIV, we also have Charlene Doria-Ortiz, Ruben Martinez, Leah Luan, and Daniel Rivas. Briefly wanted to look at the demographics of the changing Hispanic population based on census data showing that in 2010, Hispanics were 16% of the total U.S. population and will be 30% of the total U.S. population by 2050. If we look at individuals, in this case, if we look at children, today 1 in 5 children under the age of 18 is Latino, and that's projected by 2050 to be 2 in 5 children. And finally, looking at locations of the most highly populated states with Hispanic populations, the top 5 states are California, Texas, Florida, New York, and Illinois. Here's my contact information, and we will also have this for you at the end of the presentation. I'd like to turn this over to Dr. Jesus Filizola to look at epidemiology.
Thank you, Brian. Good afternoon, everyone. My name is Jesus Filizola, and I'm the Project Director for the ATC AIDS Education and Training Center at Health HIV, and also Senior Director for Capacity Building at Health HIV. I would like to start by looking at reasons why the Latino community, the HIV disease has become a major concern for the Latino community. Latinos in the United States have been disproportionately affected by the HIV/AIDS epidemic. We Latinos account for a greater proportion of new infectious and AIDS cases than our representation in the U.S. population overall. Some studies show that Latinos with HIV may face additional barriers to accessing care than our white counterparts. When acting together, several factors including poverty, lack of health insurance, cultural barriers, and immigration issues may make Latinos more vulnerable to HIV infection and disease progression than other racial minorities. Our next slide shows basically the disproportion in terms of AIDS diagnosis as reported by CDC in 2009, when Latinos comprised 14% of the population and 19% of the AIDS diagnosis. In terms of new HIV infections, also in 2009, Latino men accounted for 79% of new infections among all Latinos, and the rate of new infections among Latino men was by 2009 was 2.5 times as high as that for white men. Also, Latino men who had sex with men accounted for 81% of all new infections among all Latino men and 20% of infections among all MSM across all the ethnicities. Also, Latino MSM, the rate of proportion of infections among Latino MSM is 45% of new infections under the age of 30. In terms of Latina women account for 21% of new infections among Latinos, or accounted in 2009, and the rate of infection is 4 times higher than the one for white women. Um, the number of Latinos estimated to be living with HIV in terms of the top 10 states with the number of Latinos living with HIV. We have that New York is the top state with Latinos living with HIV, followed by California, Puerto Rico, Florida, and Texas. It's a little bit different than the distribution of Latino population being Texas, that is state with the largest proportion of Latino populations, followed by California, then Florida, then New York, and then Puerto Rico obviously doesn't count in terms of Latino population because everybody, well, mostly everybody in Puerto Rico are Latinos. Now, in terms of Latinos not being in HIV care, as we all racial and ethnic groups in the United States, Latinos living with HIV has been, the number of Latinos living with HIV has been increasing due largely to the availability of more effective treatments. That could be a reason, but also due to increasing impact of the epidemic on minorities, and that's which is observed across all the ethnicities. Many Latinos infected with HIV do not get tested until late in their infection, and also many Latinos who are tested do not return to learn about their results. Therefore, access to care is a critical issue in HIV care for Latino communities. Latinos also enter the HIV healthcare system later than other ethnic groups, particularly when it comes to progression of the disease, and we're going to see a couple of slides later regarding this. Now, other statistics in terms of Latinos and HIV and their access to healthcare services in 2010, 1 in 4 Latinos living with HIV were uninsured, a little bit higher than other racial groups, and also Latinos with HIV/AIDS are more likely to be publicly insured, with 60% of them relying on Medicaid. The impact of HIV/AIDS on Latino is part of the broader disparities in access to healthcare. Um, some reasons that studies document for Latinos not enter into HIV care are uh, factors that are not necessarily associated with medical care, such as being homeless or unstably housed, um, being unaware of their eligibility for publicly funded programs, don't need don't see a need to see a doctor, and it's still a lot of stigma and discrimination, um, highly prevalent in the Latino community. And this leads me into some cultural characteristics that can explain the delay of Latinos engaging in HIV testing and care. This slide is based on the premise that Latinos are particularly vulnerable to HIV infection because of some cultural characteristics. Even though there is little research on this specialized topic, there is at the same time compelling need to develop better theoretic frameworks for understanding the complex and dynamics of social and cultural processes influencing the behaviors that Latinos engage that may put them at risk for HIV. Some general cultural characteristics listed in this slide regarding Latinos and the delay uh, of engaging in HIV testing and care include uh, gender inequity and machismo as major factors that it may increase vulnerability to infection among Latino men and women. Machismo, which dictates the inner course as a ways to prove masculinity, and here I am making a generalization, so please don't take this that like is applicable to all Latino, but it's highly prevalent in the Latino community. And also the issue of the family, which is very important for the Latino community, the whole concept of familismo. And in terms of Latino women, most of the Latino women are caregiver first, and the Latino men are providers. So this speaks to the issue of gender roles. Latino women do not seek medical care because in most cases they are taking care of other members of the family. In some cases, family members living with HIV. So now let's talk a little bit about the progression of HIV disease at, among Latinos at the time of diagnosis. Latinos with HIV infection typically enter the healthcare system at the later stages of the disease that, than other racial and ethnic groups. It has been observed that Latinos do not seek treatment for HIV disease until it is advanced. Significantly, Latinos are more likely to delay care after an HIV diagnosis. And this basically translates into the list of common manifestations of late progression of the disease and when Latinos are engaged into care, including high number of HIV diagnoses among Latinos at the moment of the first diagnosis, high baseline viral load, very low CD4, so impaired immune status, and increased morbidity and mortality, sometimes associated strictly with HIV, sometimes associated with other comorbidities. Now, let's transition into the next item in the agenda for today, which is some approaches. Let's take a look at some approaches to optimizing HIV care for Latinos. And in optimizing care for Latino clients living with HIV, we first must look at the larger healthcare system and how Latino patients frequently engage in HIV medical care. And some of the approaches that may have a big impact in the way Latinos engage with the healthcare system include or may include integration of HIV services into healthcare systems where Latinos are frequently engaged in care, the provision and delivery of culturally appropriate HIV care for Latinos, and also the evaluation and implementation of existing care models, the whole issue of workforce development and target training strategies for a new workforce that is going to be exposed to a new number of Latino under living with HIV under the full implementation of the Affordable Care Act. And lastly, identify areas for new research and program development. And in terms of the first item that I listed in my previous slide, which is integration, why integration? Well, integration has a lot to do with supporting the national HIV/AIDS strategy. The national HIV strategy, as many of you may know, has three main goals: to reduce HIV incidence, that's the first goal; to increase access to care and optimize health outcomes, that's the second goal; and the third goal is to reduce HIV-related health disparities. When it comes to Latinos specifically, the national HIV/AIDS strategy establishes that by 2015, the country should increase the proportion of newly diagnosed clients linked to clinical care within 3 months after their first diagnosis from 65% to 85%. And by 2015 also, the study establishes that an increased proportion of HIV diagnosed Latinos should be undetectable in terms of viral load, by increasing this percentage to 20% by 2015. Now, in terms of the cascade of HIV care and that has been developed by Coroner and published in 2011 just briefly take a look at the slide, and the idea is that from a number of individuals that we know have been diagnosed, we have been able, as a whole system, we have been able to retain in care only 50% of the individuals. That will be the fourth bar of the graph, and only 24% of those individuals are virally suppressed, and that has enormous implication when it comes to Latinos, as we are about to see. The HIV/AIDS is definitely a changing epidemic, and it has changed based on and due to scientific advances that have significantly changed the course of the epidemic. Now we have a 3 single tablet regimens for clients versus the multiple pills that we used to have 10 years ago, and improved side effect profiles and reduced daily pill intake that has significantly improved adherence, leading to success in virologic suppression. And it has changed, the epidemic has changed not only in terms of engagement and retention in HIV care, but also in treatment of comorbidities and other associated morbidities. Now, how can we make integration happen? Well, just briefly to mention 2 models that have served as basis for the whole concept of integration in HIV care. One of the models is, I'm not going to go into detail in explaining the models, but I believe that most of us are familiar with the model of primary care and also the model of the chronic care model. And lately, we have been exposed to the whole concept of client-centered medical home, which is a model that has striking similarities to what the Ryan 1 model is. It is widely agreed that the medical home model is the optimal means of providing truly integrated care services. However, the majority of care in the medical home model is centralized, where culturally competent care needs to be provided, and that has enormous implications for engaging and retaining also Latinos in medical care. And with this overview of approaches to optimizing care for Latinos, I will turn the meeting to our next presenter. Next slide is my contact information, and thank you for attending this training today. Our next presenter is Charlene Doria Ortiz, Program Manager with Bexar County Ryan White Program.
Thank you, and I want to thank the Health HIV for asking me to participate in today's session, and also for my other panelists who are providing such important and rich information about Latinos and access to health care. One of the things I'm going to speak about is our perspective here in San Antonio, in Bexar County, Texas. One of the things is, you can see our HIV prevalence rate, our cases, and 55% of those are Latinos. So in San Antonio, we are a majority minority city. We're 58% Latino or Hispanic in our city of San Antonio. Most of our clients are of primarily Mexican origin, and Texas, as you saw how many cases we have, is a very late-to-care state. The statistics that were presented earlier about between a Latino taking an HIV test and then being diagnosed with full-blown AIDS is about 12 to 18 months. The other thing is, we are a border state with Mexico, which means that we have other issues like tuberculosis that are in conjunction with the clients that we have that are diagnosed with HIV. one of the things that I was asked to speak about was what are the policy issues for Latinos. The first one is that there's going to be reauthorization of the Ryan White in 2013. And Latinos need to be at the table to represent our very diverse Latino population. It is critical that the Ryan White legislation retain the absence of citizenship as an eligibility criteria. When you go for Ryan White services in the eligibility criteria, you don't use citizenship. You use residency. They ask you where you live, not where your country of origin is. And given the areas with high Latino populations, all of us, as if you've seen in the previous slides, we have many high rates of uninsured, high rates of poverty, high rates of a large number of women of reproductive age, which makes us, in particularly, our profile for vulnerability, high teen pregnancy rates, and as you saw in the earlier slides, we're a very youthful population. The other thing in the Ryan White legislation is that there's 75-25 split of how you do your money. A minimum of 75% must be spent on core medical service and 25% on a maximum of 25% on supportive services. And at times, given this profile of high rates of poverty, the needs of Latinos, they won't even come into care. So you can put a lot of money in outpatient ambulatory care and in drugs, but if they won't access it because of lack of transportation or you don't have food bank or food vouchers. So one of the things we may want to explore in the Ryan White reauthorization is the 75-25 split and allowing local jurisdictions in order to develop their own split of what will get and retain clients and service, in particular Latinos. Next slide, please. The other one is the Affordable Care Act and the limitations for Latinos. The Affordable Care Act is citizenship-based, and the other one is that legal immigrants are excluded from Medicaid. And then the other one, the most important one, is, as many of you know, Texas is an opt-out state around Medicaid. So if we don't do the expansion under the Affordable Care Act, where will that leave us? Because our Medicaid system currently, right now, focuses more on women and children and is not very compatible or very receptive around men accessing Medicaid. So if we opt not to expand Medicaid in our state and one of the largest states that serves Latinos, where will we be? So the other one is that there is a section of the Affordable Care Act that each state must determine their essential benefit packages, and Latinos need to be at the table around when those essential benefit packages and those decisions are made. And then what are we going to do with the states that opt out for the expansion of Medicaid, like Texas is planning as currently that they will do? The other one is the Center for Disease Control and Prevention and their testing initiatives, both their targeted testing and their routine testing. The communities at large can benefit for this, but what will it do, routine testing in particular, for Latinos? Because we have currently limited access to healthcare systems. And so if we don't go where places, except perhaps emergency rooms, how will the expansion of routine testing truly expand testing efforts to identify those who are positive in our community? So it needs to be a balance between routine testing and targeting testing strategies, and the targeting testing strategies need to be community-driven and culturally based. And I think the emphasis in the earlier slides on culture, I have three what culturally based means to me and how we implement it here in our Ryan White program is you take culture, you take language, and you take literacy. Health literacy and literacy rates. Those two things are the package that make the best and most efficiently designed programs. And then I love what the doctor said about what we need to look at for understanding where we need to do better and how we need to do better. It was, I think he used the term developing theoretical concepts, because I'm not such a fan of waiting until all research is developed as to I think, como dice mi mamá, like my mother says, common sense, she ain't so common. And sometimes we need to use a common sense approach to our populations. We know what we know, and we know what our community needs. So we need to develop better outreach, testing, and access to care and retention and care strategies. We need more information or theoretical concepts or theoretical models on how do Latinos use technology. In this one, what is the male behavior of both men toward men and men toward women around sexual behavior? And we have very little research around that, especially if you saw the statistics on young men who have sex with men. Do our men identify as gay? Do they sleep only with men? What is their sexual behavior with men and women? And what does that mean for developing prevention strategies? And then the identification of social networks and the barriers to condom usage, both to female condoms, which I think are very underutilized in the Latino community, as well as male condoms, and then effective risk reduction tools and strategies. How do we keep those that are negative, and how do we engage them in an effective risk reduction strategies if they're going to continue to repeat high-risk behaviors? Another one that I would like to add there that I don't think we know a lot about is bilingual bicultural discharge planning from criminal justice system. I think we have higher rates of Latinos in the criminal justice system, and I don't think we do justice by them in their discharge planning out to communities to seek access to care if they're HIV positive. So I don't want to end on a downer. I want to give you that we have had some successes in our jurisdiction, which is a 27-county region in this area in Texas. We have developed bilingual, bicultural, low literacy, and visual strategies for Latinos. I invite you to go to hiv210.org and look at our very colorful and visual videos and our website there. We've developed health diaries in both English and Spanish that Latinos can take to their physicians in their next appointments to remember medication, to remember CD4 counts, viral loads. As all of you know, HIV is an exceedingly complex disease. It's a lot to remember, especially when you're low literacy or when you're low health literate. And then we've developed a bilingual comprehensive guides for providers, and then a mini resource guide specifically to Latinos where you can go to get tested and where you can go get access to care. The next one that we have is we're developing and we're pilot testing fotonovelas targeting women in 3 age groups, doñas, my age, the older woman, damas, the middle-aged woman, and jovencitas, the younger ones, and with the theme of testing and condom usage. And these have currently been piloted very successfully. We're going to be presenting at the All Grantees meeting for HRSA at the end of November. And then I think another successful strategy has been the use of community health workers or promotoras. And I think that one, really, I think we're biased toward women there, and I think we really need to have more male promotoras and as client navigators to help Latinos navigate the unfamiliar healthcare system. We have not been used to using a healthcare system, so it's a learned behavior. And how do we teach Latinos to effectively navigate the healthcare systems, in particular the changing ones that we're going to have over the next couple of years? So, and then last is my contact information, and I think we need to go to the next presenter. Thank you so much.
Hello, this is Dr. Ruben D. Martinez from Harlingen, Texas. I'm a medical director for Valley AIDS Council in Harlingen, also a clinical professor of OB&GYN, UT Health Science Center in San Antonio. I've been asked to review some concepts on individual, clinical, and organizational barriers to HIV care in the Latino community. We have quite a few slides. I'm going to hit some of the highlights and try to present some of the issues or problems and answers we're trying to develop here in the Rio Grande Valley in addressing HIV in the Latino community. In the question of immigration status, this is really complex. We're dealing, as has been mentioned, not only with bicultural, but with binational issues here in the Rio Grande Valley. The concept of linguistically appropriate resources really are not just the language of Spanish, but the different dialects and actually the social, cultural mores of the Latino community in South Texas and across the nation. Areas we're going to have to look at is the relationships with the legal community, assistance for legal aid based on ability to pay or free care as our Latino community increases. One of the problems that we really need to look at is the legal, cultural, social, economic barriers which have made immigration policies difficult. We're having to face currently both different foreign national policies about immigration, and here along the Texas-Mexican border, the severe problem of these, quote, drug wars. Unfortunately, that sometimes leaves our HIV patients in limbo, fearing isolation, identification, and possible deportation. Invariably, all of these contribute to the lack of health care. What we're seeing very frequently also is separation of families. A lot of our patients are binational. Families are spread both in the U.S. and throughout different states and different states, predominantly in Mexico and also in South America. Okay, next slide.
You bear with us. We're having technical difficulties, and we've given back control of the slides to the folks in CC. If they can advance to the next slide for us, please. Thank you. Slide 45.
Okay, we seem to be having some difficulty here moving our slides, so let me just continue to discuss the issue. I think with the issue of public health within the community, eventually on a national and state level, we're going to have to become far more involved in the national dialogue about the necessity of providing health care to all of our inhabitants, both legal and not legal. The importance of cost savings by inclusion in early diagnosis, treatment, and management, The decrease in the cost burden by not excluding our Latino patients into healthcare. And really, we need to heighten both in the statewide and nationally public support for healthcare as a predominant human right. Question of language barriers, I think of extreme importance is wherever possible bilingual staff, where translators are useful. I think it incorporates another potential for loss of healthcare information and mistranslation. And I think that patients respond very, very well to their providers, be they physicians or mid-levels nursing staff, to understanding their language, their cultural, diets, physical activities, and just even some of the colloquialisms that are necessary in establishing the physician or provider-patient concept. What we find here is that patients are going to be far more receptive in seeking care and following up with their follow-up care when they feel like their provider can understand not only their language but their moral views and religious views. Again, the importance of linguistics within the healthcare provider in the Latino community is exceedingly important. Within the clinic area itself, signs and appropriate languages here in Spanish. Of course, the multilingual staff is without precedence, and simple written materials in Spanish at different reading levels that allow incorporation of our Latino HIV patients into the healthcare system. Again, we're still having problems with our slide, but in dealing here with the fear of disclosure is exceedingly important to the Latino population, be they American citizens or not. Some of these families are split in the fear of detachment from their loved ones, patients, and otherwise. What we're doing here in the Rio Grande Valley is establishing Latino support groups to address the question of men who have sex with men, women, transgender patients, and the concept of hepatitis C, its treatment, diagnosis, and adherence. HIV education, both on a provider-patient basis and to the community. With any chronic diagnosis, especially one which is, quote, untreatable like HIV, most patients are going to be very, very greatly bothered by it. They're afraid. They have to face their own question of mortality. One of the things that we've tried to do here at Valley AIDS Council, the Rio Grande Valley, and for those of you all who are familiar with the state of Texas, is this concept of one-stop shopping. There is a big grocery store line here in the state called HEB, and one of their logos is Follow Me HEB. And one of the things I keep stressing for our providers and our mid-levels is this concept of follow me to VAC. We basically have to offer complete access to health care, not only in the diagnosing and the treatment, but in the ability to facilitate access to our patients to, say, completing applications for eligibility for Medicaid, Medicare, the ADAP or the AIDS Drug Assistance Programs, for possible applying for Social Security Assistance, the Ryan White HIV AIDS program, and for nutritional supplement programs, which are exceedingly important in allowing us to fully manage our patients appropriately. Finally, one of the things we're doing here also is trying to gain access to local TV and radio TV shows to outreach to our community. I think that with a group like what we have online right now, one of the things to consider is going on a national level and perhaps making contact with some of the Spanish Latino TV networks, shows like Cristina, Siempre en Domingo, Sábado Gigante, would be an invaluable source in maybe in over a 5 or 10, 15-minute session, contacting and addressing the issue of HIV in the Latino community, not just at a local, but at a trans-state and international basis. Some issues dealing with the economic factors. Most of our patients, or a large proportion of the Latino population, is going to need basic assistance with health care and finances, availability of social services, seeking food and housing assistance, questions of domestic violence, which are often not discussed in the Latino section, and of course legal aid and immigration services will help incorporate the HIV patient into the healthcare system and or to allow them to seek care. Of great importance, which has been touched also, is the increased incidence of HIV infection in the incarcerated populations. One of the things we've been doing here at Valley AIDS Council is trying to work with our social workers and some of our contact educators to go to some of the local detention centers, prisons, and try to initiate a program of HIV testing on admission and on discharge. As an OB-GYN specialist, one of the things that really concerns me is the very, very high incidence of positive HIV women when they are incarcerated. I think this is an area where we have not really paid enough attention to. If you all have access to slide on page 49, dealing with the challenges of adherence. Here again, communication difficulties are a major concern. Clients' attitude about disease and therapy may be totally different from the non-Hispanic and non-Latino healthcare provider. Access by phone, extended office hours, allowing patients to walk in, we've noticed over the last year has really increased adherence to compliance to office visits and to health care. We have to really demonstrate not only on the educational level, but on the primary care physician and the patient level that we actually care for our Latino patients. It can't not just be based on language or social cultures, but the patient needs to feel that they're cared for, that individually they have an asset to offer to their family and to their community. And I think here the ability of the healthcare provider to bond, if one would say, with the patients, taking time to ask them how they're doing at home, ask them about their environment. In the pre-treatment teaching, it's been shown many, many times that the patients, Latino and otherwise, are going to be far more receptive to initiating treatment and to staying on treatment once commenced if before the treatment process is initiated, they get a good understanding as to the pathophysiology of HIV, its chronic nature, and the need for self-identification and identification of when the patient himself or herself is ready to initiate the progress. Proactively addressing this concept of need for continued care, we find has improved retention within treatment and follow-up programs. On slide on page 50, and again, we're still having technical difficulties, the question of using peer educators in dealing with the Latino population has been exceedingly helpful, reinforcing treatment adherence, geared at different social cultural levels and literacy levels. One of the things that I find also is the use of cell phones, having our patients program their cell phones to ring at a specific time to remind them of the need to continue their HIV medications. Some comments on the slide dealing with identifying acute HIV infection. This is certainly a tremendous problem throughout the entire medical community in the United States. A lot of our primary care providers, family practitioners, OB-GYNs, are really not attuned to the concept of the identification of the acute HIV infection. And I think here in reaching out to the medical schools, the teaching programs in nursing, the social work programs in our community has been very useful. I think we basically need to present HIV as we did in the past diagnosis of tuberculosis and syphilis, to have a high incidence of suspicion, not be directed just by lifestyle choices that our patients make or we assume that they make, is going to be an exceedingly important area. The difficulty in, of course, diagnosing acute HIV infection is its highly nonspecific symptomatology and lack of awareness, predominantly not just by the non-medical community, but for those of us who are in the primary care sector. I'd like to make a few comments on the slide on page 52, which deals a little bit more with ineffective communication and lack of trust. I think this is of extreme importance. Any patient, Latino or otherwise, is not going to follow up with care if he or she feels that they cannot communicate with their healthcare provider. Here, I really think that we, the healthcare providers, to quote St. Paul, really have to be all things to all people. It is our responsibility to familiarize ourselves with the language, cultural, traditional home remedies, diets, cultural values that our Latino population and subpopulations are used to. The use of HIV positive peers in educating and helping the patient navigate through the process of healthcare, advocacy for the patients, and where need be, language translation and psychosocial support. More difficult, certainly in the Rio Grande Valley, is this integration of medical care into outreach programs between Texas and Mexico. With the current concept of the drug wars, traveling by patients or healthcare providers across the border has become more difficult. Certainly in the past, it was very common for me to go with my med students and residents, both to teach and to provide health care in Mexico. This is becoming a legal and a risk concern, which has cramped somewhat our ability to have transnational support structures. I would just make a few more comments on this ineffectual communication with our Latino patients. It is important to reach out to both the non-clinical and clinical staff training with cultural, language, competency in dealing with our Latino population and subpopulation. Ultimately, though, although interpreters play an exceedingly fine role, the staff being bilingual, if possible binational, is going to be exceedingly important in allowing the Latino HIV patient to incorporate himself into the treatment modalities and continuing protracted health care and follow-up. If I may make a few more comments now on the organizational level, we have slides 54 and 55. The importance here is to remember that all of us at one time or another are or will become patients of one sort or another, and that most diseases or medical conditions that take us to the physician are going to be chronic. The importance of establishing the chronicity of HIV infection to the patient. Yes, it is a chronic disease, it is incurable, but then making our patients understand that most of the disease processes that we humans are going to be facing, whether it be hypertension or diabetes, weight issues, are chronic, and we have to be a little bit cautious not to overemphasize the non-curability of the HIV. I think after the initial shock of the diagnosis of HIV, like with any other disease, patients tend to become lax, and we sometimes forget that our patients have their own life to go on about, their own job requirements, families. In trying to address these issues, one of the things we've been working with here at Valley AIDS Council is flexibility in scheduling, allowing double booking, and certainly allowing walk-ins, keeping open slots for emergency admissions, and running different hours, late hours on several days of the week, so that we can comply with the needs of our patients and their job requirements and their family requirements. I would like to just wrap up. I know we're running a little bit late, and just to reinitiate the concept that HIV is not curable, but it is a totally controllable, protracted chronic disease, that we need to get away from the fear that it is incurable, that it is totally manageable, and we need to make every effort with our Latino population to integrate them into the healthcare system through appropriate, culturally appropriate and language appropriate counseling and incorporation into healthcare. Again, I'd like to thank the organization for letting us contribute to this excellent program, and I apologize for the technical difficulties we're having here in our area with our slides. Thank you.
Buenas tardes, good afternoon. My name is Leah Lujan. I am a family nurse practitioner at a local community clinic in Washington, D.C. by the name of La Clínica del Pueblo. Just to kind of give you a little bit of background on who we are. We started in pretty much in the late 70s, early 80s as there was one volunteer doctor that would come to a local agency that was mostly advocacy, Latino advocacy groups, as well as like English as a second language. It was sort of a catch-all beginning of the community organizing in Washington, D.C. And out of that sprang our clinic. Just a little bit of what's sort of details about us. The majority of our patients are Latino immigrants. I'd say the majority of those majorities are from El Salvador, which is we have many people, consequently, who have, based on history, the long history of war. We have many people who have come here alone. We have many others who have brought up their teenagers in the last, number of years. We have many with very low literacy rates. We do have, as many primary care clinics, we do see a large percentage of female patients. One of our sort of commitments to quality care is working on having 40-minute annual visits, and that includes the first-time diagnoses visit as well. We usually do about 20-minute sick visits. If available, we'll do longer. We have an open access program which allows patients to be seen either the same day or the following day, and we always also allow for double booking and that sort of thing to make open so people have limited, as much as we can do to limit the barriers to care. We feel that clients engage really well with the staff. We have a large percentage of the majority of the staff here at La Clínica are from different countries and are pretty representative of the sort of the numbers in the Washington, D.C. area. We have, in terms of access and barriers to care specific to HIV, obviously with many people, there are a lot of conflicts between work and medical care, time-wise. People who have many different jobs, that sort of thing, instability, lack of availability of housing. We find we serve, in terms of HIV specific, we are the only Latino specific agency in the district that serves the HIV community. And in fact, the access in the DC area is also quite limited. So we also see patients who and individuals who live in Virginia and Maryland as well. That may be sent here. We will have hospitals will refer people immediately when they're still there, so that we do an intake through the hospital setting. immigration issues obviously play a big part in access to care, as I'm sure everybody has experienced. The stigma also is nothing new, I think, and working along with everyone else to work on discussing and teaching, having the conversation about how this has become a chronic disease and manageable, and having the resources available to do that. Many of our patients are undocumented, and consequently it can be difficult for maintaining continuity of care. One of the things that has allowed us in Washington, D.C. in particular to have, in terms of primary care in general, we do not, there's a sort of how D.C. decided to spend their Medicaid funds. They used the monies to provide a sort of standard health insurance to individuals, and it didn't, it was regardless of whether or not you had children, you could qualify, and regardless of whether or not you had a Social Security number. So it doesn't, so your legal status doesn't matter. You just have to prove that you live in D.C. and make under a certain amount of money. Cultural and religious factors also can cause individuals to not seek treatment. We've had people come in before with information saying that certain churches have said that they can cure things, or it's not a real disease, or promises of others to cure things, or people coming in and afraid that there's brujeria or something like a witchery that is causing this, and that it's really not a real disease. The services we provide at La Clínica are pretty comprehensive across the board. We do general medical services for the full family, which is good as well for patients who are, in families and want to have care in one location, whether they're HIV positive or not. We have chronic care management, our HIV management services, which include not only extensive outreach and testing, which we do all over the city, but we have sort of what Whitman Walker calls a red carpet service, which essentially means that once you are swabbed positive, then you are automatically kind of pulled into the system where you speak to case managers and you see a provider the same day. So all of these things can get incorporated from the beginning. The benefit of that is obviously very deep. We also have a very strong mental health program. I had a newly diagnosed patient last week who, within the same day, I was able to have him see one of our counselors as well as case management, so that's been quite successful. The language services, we also provide interpretation across this town. So if someone needs to see a specialist for any reason, or to get testing, which we cannot offer here, we always send people with an interpreter, trained medical interpreter, which makes a huge difference, I think, for understanding particularly. We also have a youth group that's called Empoderate, and they have like their own space, which is wonderful, and they do lots of outreach. And so in general, the sort of a little background into sort of the Latino provider workforce, and part of these numbers are really kind of addressing the issues which we all know, which there are not enough providers out there who are Latinos, and that in terms of addressing some of the cultural and linguistic competency issues, access to care, understanding of treatment plans, understanding of diagnoses, understanding is really very important for the idea of really doing capacity building from that perspective for providers. Obviously the need for primary care MDs is huge. And I think that's part of the reason why nursing at least has stepped up a bit in terms of increasing the numbers of nurse practitioners as well to help meet that role. The number that's kind of stunning is the 3,000 Latino patients to each Latino physician, and for non-Latinos it's 335 to 1. That's pretty remarkable. Myself personally, I have had the great fortune. I am a new nurse practitioner and have been at La Clínica for the last 4 months. I worked at La Clínica many years ago as a social worker, among many roles, many hats that you play in a community clinic. That was one of them, and I recognize the need for providers who were bilingual and bicultural. So that sort of was my impetus to go back to school, which I did, and I've come back to work at La Clínica now. I have had the great fortune of being accepted for the Health HIV mentorship program, so the Workforce Capacity Building Initiative, which has allowed me to work very closely with Susan LeLocher, who is a specialist at GW, and I have been able to, as an individual, as a practitioner, gain so much information about, learning better how to interpret genotyping, how to care of a patient with substance abuse or other comorbidities, or understanding resistance, sort of complexity of care, access to reliable resources, that sort of thing, which is greatly needed. In our community clinic, we have one full-time provider that sees HIV-positive patients, and we have 2 part-time, and one of those only is here for 1 afternoon a week. And our numbers are unfortunately they're increasing every day. We have more new patients, and it's important for us to be able to open up the doors to more patients, which was my great fortune that I was able to participate in Health HIV, and I am now seeing my own patients, and I continue to have the mentorship and the availability to have support, reviewing cases, things like that, that really foster my ability as a clinician and to ensure that I'm providing quality care and competency, obviously. So this talks a little bit about the initiative design, which is the idea of mentoring clinicians in primary care practices, community health centers, matching physicians, NPs, and PAs to clinical experts to do exactly what I was talking about, and offering the resources, which is absolutely huge, because as anyone knows, to find anything through the internet, I mean, you can Google away and not be sure where it is that you're going to find the most reliable sources. There is my contact information. I again want to thank Health HIV immensely for the work they're doing, and in particular, obviously, Susan LeLocher, who has been absolutely brilliant. And thank you for your time.
Good morning, everyone. I want to thank Health HIV for asking me to be part of the panel. I also will be highlighting a few. I know we're running behind, so I'm going to highlight a few of key points that I think I want to highlight on my slide, because I really think that the presenters before me have done a great job doing a comprehensive, capturing a comprehensive image of the issues and challenges in working with the Latino community. Let me start off with talking a little bit about St. John's, and I think I misplaced the slide, but I want to start off with this one. St. John's, we're located in South Los Angeles, which is known to be a hotspot of HIV in LA County. We're a network of 10 health centers. We have health centers, we have school-based clinics, and provide quite a few services, which is this slide here. Again, we do a lot of wraparound services because, as some of the previous presenters have mentioned, we also think that it's important to have sort of that one-stop shop model, as well as, looking at the center and medical home model to make access to care easier for our patients. St. John sees a lot of uninsured or publicly insured individuals. And South LA historically has been known to be, primarily African American, but recently has really become more Latino. And again, it does vary from Mexican American or Mexican to Central American, Salvadorian. So the Latino community in South LA is very diverse as well. So here are some of our other programs. I think this is what I think this makes St. John stand out from some of the other clinics, is that we really try to look at keeping our patients at the one-stop shop. And this is why, it's been our experiences that Latinos will go into a provider and put their trust in them. So I hear a lot is Latinos or our patients will say, lo que diga el doctor, lo que diga la doctora. So when we started doing HIV or routine HIV testing, it was really important for us to remember that and making sure that the patients were aware that it was opt-out. So they had the option to opt-out, so they didn't feel forced. We started our routine HIV testing program about 2 years now, and I think it's been successful because, again, the patients are putting in a lot of trust in the provider, and I think it's just a cultural thing that they go in there giving trust to the provider. So we have to respect that and acknowledge that and honor that. I think I know the HIV patients that we have seen in there have come in not because they thought they were HIV positive, but because they had a different issue, whether it's shingles or just not feeling well. They came in there to get better, and it wasn't specifically for HIV. And they talked a little bit about earlier in the presentation about some of the cultural characteristics that delay, care. And that's not just for HIV care, but that's just medical care. We have, as Latinos, and I include myself in that, we just have other priorities, career, school, family, religion. It's not until we really are sick that it keeps us from taking care of our family, going to school, that we actually choose to go to a doctor. So just wrapping up, I think we know that Latinos aren't getting tested until late in the disease, and they're not coming back for follow-up because the belief is, I'm feeling better, I must be fine. So we have to continue to follow up with our patients. We have to, remove some of these barriers. One of those barriers, and I think that an important barrier to acknowledge, is that as soon as they become diagnosed, and I know it's difficult for health centers to do HIV care sometimes or integrate it into their primary care, but as soon as we diagnose them, we're sending them away. So we're moving them out of our clinic where they've sort of given trust to. So I guess as much as possible, if we can try to integrate HIV care into our primary care services, I think that would help keep our patients. Again, I have on the slide here, I have to go to another otra cita or otra clínica. It's, again, we're sending them out. We're putting up more barriers because, again, transportation is a big barrier for a lot of our clients, child care. And, again, they're going to have to take time off for work, which is already stressful enough that they took one day off to come to our visit. And then to ask them to go again to another clinic, I think we have to look at using our promotoras as well once we do get them and keep them into care. What we've done is we refer them internally. We do have a lot of services that allow us to keep our patients inside, and once we have those patient navigators, the promotores that we use, it helps keep the patient in because we have a contact person that they can go to. So they don't always have to go to the provider. It may be a simple question that a promotora can use or can answer. And if the promotor cannot answer, then we connect them back into our providers. So, I think, and if we can integrate HIV primary care or HIV care into our primary care services, That's important because we saw a lot of patients not wanting to go to the HIV clinic because it was a known HIV clinic. And so again, there's that stigma that people are afraid of. So client engagement, we need to try to keep them in sort of one location. And if we send them out to somewhere, make sure they're true links, that there's a connection made, that it's not just, oh, here, go to this site. But if you're sending them out, tell the patient, talk to so-and-so, they'll follow up with you, or give them a name, give them a contact person. And again, look at the whole client when it comes to HIV and not just, how will HIV affect their everyday life? Sorry for such a rush through, but I know we're running late. So here's my information. If anybody has any questions, please feel free to contact me. Thank you again.
Jesus Solisola again here, and I know that we ran out of time definitely, so I'm going to be very brief. Thank you so much to all the panelists for such a wonderful presentation and that wealth of information and experience that they have shared with us and the rest of the attendees. Briefly, a couple of words before closing the webinar today in moving forward and in reviewing what we have learned today. There is so much to do in terms of promoting integration of HIV services in primary healthcare facilities that work typically with Latinos, and definitely understanding and engaging in understanding and embracing cultural differences and barriers within the Latino community to address issues that or barriers, should I say, in terms of engaging Latinos in testing, treatment, and prevention, and definitely more guided research to understand where Latinos fall within the cascade of HIV care. And as Charlene said before, or reiterated, more theoretical frameworks to understand the way Latinos engage in HIV testing and care services. Again, we ran out of time. There will be one last slide, and if there are any questions, please email us your questions to this email highlighted right here, Shona at HealthHIV on the last slide, and we will be more than glad to refer your question to the appropriate panelists. Thank you so much again, and for such a wonderful webinar, and thank you to all the attendees.